Allergic inflammation concept. In this animation below, we would like to introduce an allergic inflammation concept. This concept attempts to illustrate that allergies is a systemic disease rather than just itchy nose. The symptoms of allergies in the nasal area commonly associated with allergies are just the tip of the iceberg. Those are just the beginning of a process of allergic inflammation that involves the lining of many organs in the body. It starts with an adaptive immune response to organic materials from the air through interaction with colonizer immune cells along the airway from the nose throughout the airway down in the lungs. Those organic materials are mostly wind-pollinated pollens found abundantly in temperate weather parts of the world, particles of pet saliva and dander circulating inside modern home, and airborne respiratory viruses plus different types of organic dusts. At first, inflammation symptoms are started at the nasopharyngeal area. The sensation originated from this area is strong and is noticed first due to abundant of nerve-ending sensation to this area from the brain. The size of common allergens like pollens is about 20 microns and is relatively large to get to the lower airway. Therefore, nasopharyngeal area is first to get stimulated and noticed. Typical symptoms are presented similar to a cold or a flu and more frequent during allergy seasons with recurrent nasal congestion, sore throat, postnasal drip, sinus pain, sinus infection, ear pain, ear infection, tinnitus, hearing loss, headache, and migraine. The inflamed mucosa leading to increased mucus production that facilitates the overgrowth of microbes that normally colonize there. This overgrowth of microbes might lead to bad breath and infection. Infection in those areas is oftenly referred to as strep throat, sinus infection, recurrent ear effusion and infection that can lead to future hearing loss. Interestingly, symptoms are not seen to perceive strongly or not at all in smokers and individuals with severe eczema. In eczema, severe skin irritation likely distracts the sensation away from the nasopharyngeal area. In cases with heavy smoking, this lack of early sensation is likely due to the downregulation of nerve endings in the nasopharyngeal area. Those individuals are often presented for evaluation when serious complications occur like severe sinus infection, bronchitis, or ear infection. Over time, with persistent stimulation at the nasopharyngeal area, inflammatory cells in this area continue to send signals out to allergy cells in other organs in the body, causing remote allergic inflammation in places far away from the nose. At this point, it seems like the same inflammation started to migrate down to the lower airway in other places. When inflammation develops inside the lining of the airway, it starts a process of inflammation called asthma. However, since we do not have sensation of itchiness, pain, or burning in the lower airway, early onset of allergic inflammation in this part of the body is oftenly ignored. When the airway becomes inflamed, it also starts to produce mucus. It also causes smooth muscle wrapping around the airway to contract intermittently, leading to a cardiac response by an increase in heart rate that is oftenly interpreted as having bouts of anxiety. However, at this early stage, we do not develop out-blown symptoms of asthma that are usually described and known of as asthma attack yet. At this stage, the symptoms are vague and are usually attributed to psychological problems like anxiety, panic attacks, chronic fatigue, generalized ache and pain. Other common problem of untreated asthma is halitosis, recurrent bronchitis, or bronchopneumonia. The bad breath is likely emitted from chronic mucus production in the lower airway. This layer of mucus plus overgrowth of bacteria colonizers, creating a microbiofilm that emits bad breath. In contrast to the upper airway, it looks like gut bacteria colonizes in the lower airway. Therefore, bad breath in untreated asthmatics emits odors that are similar to that from the gut, and infection of this biofilm is called bronchitis or bronchopneumonia. When this occurs, this biofilm might complicate asthma treatment with inhalers alone due to the inability of this topical medications getting access to the airway mucosa. The inflammation process in this disease is mediated mostly by adaptive immune response. Therefore, asthma develops in a much younger age group in contrast to the very slow process of COPD, a mostly innate immune response process. Inflammation in the lower airway is called asthma. It would take a strong stimulation to cause asthma attack at early stage. Asthma attacks are frequent when the inflammation is severe and the airway becomes small. The severity, duration, and extension of inflammation and remodeling of the airway define the severity of this disease. Asthmatic symptom of shortness of breath is likely the sensation from the inflamed airway mucosa, but not from the lack of oxygen, which is mostly the disease of lung parenchyma or alveoli, like in COPD. Therefore, except from rare cases of life-threatening severe acute asthma attacks, most symptomatic shortness of breath in asthmatics would have pulse oximetry in the high 90%. In contrary, an asymptomatic COPD where the damage is at the alveoli would normally carry a pulse oximetry around low 90%. Therefore, contrary to conventional belief, asthmatic airway is a fluid process of inflammation inside the airway lumen. Asthma is not defined only by asthma attack. The risk and rate of developing a lower airway inflammation seem to associate with the intensity and duration of allergens exposure, plus genetic predisposition to the developing inflammation in the lower airway. It seems that individuals with direct family history of asthma tend to develop this inflammation in the lower airway faster than the ones without family history of such. Interestingly, in the U.S., it seems that populations that migrate from areas without plenty of aeroallergens, like the ones closer to the equator, tend to develop this type of inflammation a lot faster than populations that have had this exposure over thousands of years, like the ones from Europe. It likely explains how minorities living in the U.S. seem to develop asthma and its untreated complications faster and more common than that of Caucasian descents. When individuals with this condition continue to expose to aeroallergens, inflammatory cells in the airway from the nasopharyngeal area to lower airway in the bronchial trees will continue to emit signals elsewhere. The surface area in the nasopharyngeal area is estimated to be around 160 square centimeters. However, the bronchial tree total surface area is relatively large and is estimated to be around 2,500 square centimeters. When both upper and lower airways are inflamed, there is very large surface area of inflammatory cells that can drive inflammation faster to other places in the body. Since allergy cell is a type of immune cells and is colonized in every organ in the body, one would start to see allergic inflammation starts to show up in other organs remotely from the nose and the lungs. In later development of allergic inflammation, one could develop similar allergies inside the gut, causing abdominal bloating, loose stools, and urge for bowel evacuation after each meal due to irritation of the gut from food intake. Bladder might get inflamed, leading to frequent urge for urination. Some other times, dysphagia might also be linked to this condition. Skin also shows signs of activated mast cells with intermittent spontaneous urticaria and angioedema, which is often perceived as sensitive skin. Eczema, an allergic inflammation of the skin, can be seen in any stage of this allergic inflammation. When this occurs, allergic inflammation seems to be more severe with high level of allergy antibodies being produced. This overly high level of allergy antibodies likely due to direct stimulation of underlying allergy cells through a large surface area of damaged skin barrier, and the frequent colonizing of commonly skin pathogen called Staphylococcus aureus. When stimulation from nasopharyngeal area and the lower airway is persistent and chronic, we might theoretically see inflammation is induced in many other internal organs or their linings where mast cells are colonized. Misdiagnosis and delay of treatment due to lack of appreciation of its systemic effects might lead to significant loss of quality of life, productivity, and cost associated with delayed treatment.